Hello, my name is Achao, and today I'm going to be telling you a little bit about germ cell testicular cancer. You'll find out why I put a picture of this plant here later. So, we'll go over what testicular cancer is, including its symptoms, etiology, epidemiology, and different types of germ cell tumours. And finally, I will finish by briefly touching on the treatment. We won't be talking about staging or diagnostic tests because I want to focus more on the actual disease itself and the etymology related, rather than the clinical aspects. I chose to focus more on germ cell tumours rather than somatic cell tumours because they are by far more common and there isn't enough time to go over all of them. So what is testicular cancer? Testicular cancer is a cancer that develops in the testicles. It's obvious, right? It's an umbrella term which comprises of a number of different types of neoplasms, depending on the cell of origin and age of presentation. The most common are germ cell tumours, which account for 90 to 95% of all cases of testicular cancer. The word germ comes from the Latin German, which means bud, seed or embryo, and so hence germ cells are sex cells. Under germ cells are seminomas, which itself comprises of 40% of all testicular cancer cases, and non-seminomas, which makes up mostly the rest. Regarding the pathogenesis of germ cell tumours, it is thought that the result from the proliferation of immature spermatogonia, as well as arrested sperm maturation as persistence of embryonic features, lead to subsequent genomic instability. We'll go through more of that later. But first, let's just quickly gloss over rarer types of testicular cancer. Somatic cell tumours can occur in the testis, usually known as sex cord stromal neoplasms, and they are relatively rare compared to germ cell tumours. They tend to occur predominantly in childhood as well. The word stroma itself comes from the ancient Greek meaning bed, and it makes sense because these cells act as a sort of bed for the germ cells. When we talk about stromal cells of the testes, we mean either one of these two. Either Leydig cell tumours, which account for 1 to 3% of cases, or Sertoli cell tumours, which account for 1% of cases. And it's clear to see how relatively rare they are compared to the other, like 95%, which are germ cell cancers. Also worth mentioning are lymphomas and secondary carcinomas, which account for 4% of cases. These typically occur in older men, unlike germ cell tumours, which frequently affect younger men. Epidemiology. Testicular cancer is a relatively rare type of cancer, accounting for just 1% of all cancers that occur in men. Around 2,000 are diagnosed with testicular cancer each year in the UK.
It's also about 10 times
more common in males of Northern European ancestry and 5 times more common in all whites compared to other races. In general, testicular germ cell tumours may occur in any age, but over 90% occur in young adult men, with a peak prevalence between 25 and 40 years of age. Testicular cancer is unusual compared with other cancers, which are often seen as a disease associated with aging, because despite being relatively uncommon overall, testicular cancer is the most common type of cancer to affect younger men. Right, so bear with me on this. It's important to learn the difference between seminomas and non-seminomas. The main physical difference between the two is that seminoma tumours cells remain morphologically close to one type of origin, one origin cell, whereas non-seminomas can have all sorts of different histological forms with potentially mixed cell types. Non-seminomas also occur in younger patients than seminoma. They are the most common primary testicular malignancy, accounting for almost 60% of cases. Non-seminomas tend to be more aggressive than seminomas and hence are faster growing. They're also frequently seen to have already metastasized upon first presentation. Furthermore, seminomas are much more sensitive to radiotherapy than non-seminomas, and where seminomas are limited to lymphatic spread, non-seminomas can use both the blood and lymphatics to get around the body. All of this means that non-seminomas tend to have a worse prognosis than its counterpart, and this is quite significant in its treatment. So, some etymology. As mentioned before, non-seminomas can arise from a multitude of different cell types. Some of these names may sound confusing, so let's go through a few. Choriocarcinoma is a malignant trophoblastic cancer which may arise in the testes or ovary or placenta. They are malignant and highly resistant to chemotherapy and has a worse prognosis of all germ cell cancers. Once broken down, it comes from the ancient Greek chorion, meaning placenta or membrane around the fetus, and carcinoma, a word typically used to describe malignant cancers. Seminoma, on the other hand, which we already met, comes from Latin, from semen, seed, and oma, which is tumour. They're tumours that arise from the seminiferous tubules. And finally, my favourite are teratomas, which are formed from a mass of cells inside a body, which form when the mass of cells inside a body grows into different tissue types. Some can even include bones and nerves and hair. Hence aptly named monster tumour from the Greek terato, meaning monster, and oma, meaning tumour. This is why I've included an image of a chimera, which is a Greek mythological creature featuring a combination of many different body parts of different animals, similar to a teratoma. And as you can see here, this teratoma on the ovary is starting to develop a little brain. It's got hair around there as well. It's just all over the place. So next, some histology. I just want to take a minute to show you some basic histology. On the top left here, you can see here is the normal cells, and here are is a seminoma cancer. You can see the lymphocytic spread, and how everything is just bigger. You've got bigger tubules, and everything's just a size up, but the architecture is still mostly there, and that's reflected in the macroscopic view. As you can see, it has a similar texture, similar color, and everything. It's just a big tumor, really. And this is different compared to, say, this. So this is a non-seminoma, and on the top right is a microscopic view of an embryonal carcinoma mixed with teratoma. And immediately at the bottom, you can see the massive cells. This is cartilage inside the testicle, and it should not be in there. And there are mesenchymal stromas around here, and there are more primitive cells up here. Note how the architecture is just completely gone. There's no more tubules, and there are cell types which just should not be in there, and that's reflected in the macroscopic view. You can see little blue islands of cartilage, weird textures, weird colours, because of all the different types of cells. Nothing like a seminoma. So, testicular dysgenesis syndrome. The exact etiology for germ cell testicular cancer is unknown, but there's a popular concept called the testicular dysgenesis syndrome concept, the TDS concept. It states that the testicular cancer is etiologically linked to cryptorchidism, hypospadias, and abnormal testicular differentiation, as they all share some common risk factors which are hypothesized to originate during fetal life. However, not all of these cases of genital malformations and infertility are part of TDS. Only cases linked to poor development of the testes in fetal life can be considered part of this syndrome. This hypothesis is supported by histological studies, showing dysgenic features that are shared, such as undifferentiated tubules with immature Sertoli cells. So, further detail about TDS syndrome. The TDS syndrome concept states that the disturbed function of testicular somatic cells here, in combination with environmental and genetic factors during early development, basically what happens is, thus depending on the severity of the impairment that these factors cause on the somatic cells, dysfunction of the somatic cells will cause disturbed hormonal homeostasis and other intermediate phenotypes such as impaired germ cell differentiation, shown here in pink, and these phenotypes can have late syndrome symptoms and consequences which I've mentioned before, such as hypospadias, cryptorchidism, and obviously testicular cancer. And there's evidence to support this as well. So 10% of all patients with germ cell tumours had a history of cryptorchidism. A patient with an undescended testicle has at least 4 times the risk of carcinoma compared to a normal testicle. And patients with trisomy 21 are 50 times more likely to have testicular cancer. So, some further etymology. Let's just gloss over some of these terms before we move on to the treatment. Dysgenesis, coming from Greek, dys, which means bad, and genesis, which is origin. Cryptorchidism. So crypto, meaning hidden, and orchid, meaning testicle. That's why I have the flower here. And it is aptly named because it's a condition in which one or both of the testes fail to descend from the abdomen into the scrotum. So it's a hidden testicle. And finally, hypospadias. It comes from the Greek man with hypospadias, but once you break that down even further, hypo meaning under, spadias, spad, meaning something torn, and this is quite rightly named because it's a congenital defect in which the opening of the urethra is on the underside of the penis instead of the tip.
Finally, we have treatment. So basically, germ cell tumours are treated predominantly by surgery, which is often the first-line curative treatment. which may be followed by radiotherapy depending on the histology, disease spread, and other prognostic factors. Chemotherapy is not typically used due to persistence and relapse being reported in a high proportion of patients. The procedure is called radical inguinal orchidectomy. The word is from Greek orchis, meaning testicle or orchid, and ectomy, meaning to cut. And inguinal is from Latin, which means groin. This procedure typically involves an incision in the groin around here with the removal of the entire testicle and most of the spermatic cord. As you can see from the image, this is done by pushing the testicle back through the inguinal canal and through the abdomen. Note the scrotum is not cut during the procedure because if the cancer is present, this could cause it to spread into the scrotum and lymph nodes. Metastatic spread is also why the entire affected testicle must be removed and not just the tumorous part.
And finally, thank you for watching. Hopefully you understand why I have these two images here. But yeah, thanks for listening.